public domain as well, so please be careful the way that you word it. So good evening. This meeting is being held bilingually, which means you are welcome to contribute in Welsh or English. For those of you who do not understand Welsh, please do the following. Scroll to the bottom of your screen. There you'll see an interpretation logo. Please click on that and then click on English. Good evening and a warm welcome to those online, to this online public engagement meeting. Welcome to our guest speakers. My name is Malcolm Latham and I am the chair of the South Glamorgan Community Health Council and a voluntary member. And I'm joined by Stephen Allen, the Chief Officer of the CHC. The Community Health Councils are the only independent public and patient lay NH watchdog in Wales. One of our key responsibilities is to represent the interests of the patients and the public in the NHS. This evening, my role is to chair this engagement meeting and to act as the honest broker in discussion. As a CHC member, I have no preconceived views or opinions as to the proposals being presented tonight. However, I am clear that my role is to ensure that the meeting is carried out in an orderly manner. This evening's online engagement meeting is to discuss the proposals for the vascular surgery and South East Wales network, vascular network in Cardiff and the Vale of Glamorgan. The house rules to be followed during the meeting are to keep background noise to a minimum. Can you make sure you mute your microphone when you're not speaking? If you do wish to ask a question during the meeting, you will need to have your video camera on and the name on the screen, unless you are using the phone audio channel. If you choose to use a web camera, be sure it is in a stable position and focused at eye level if possible. Everyone's view is important, so respect what they have to say, even if you disagree with them. You do not know the journey that that person has made. If you want to speak while someone else is speaking, raise your hand and the chair will invite you to speak when they have finished. Inappropriate behaviour will not be permitted in this meeting. Individuals will be given 2 warnings, but if they carry on, they will then be automatically removed from the meeting. Should this meeting get interrupted by a Zoom bombing hack, the meeting will close. Please then establish the link 5 minutes later on the code that you were given, and we will then come back to the meeting. Before I introduce the main speakers, I would like to draw your attention to the online response form that was emailed to you and is also available on the CHC and Health Board websites and can be downloaded or requested. It can be sent to you by post. Also, as a public body, the CHC and Health Board have a duty to take into account the impact of their decisions on people with protected characteristics as laid down by the Equalities Act. To assist with this, you are invited to complete the online questionnaire, which has been emailed to you, and then email it back to us. A record of the discussion is being taken in order to validate what has been said. I intend letting the presenters finish their presentation before opening up the matter to the floor for questions and discussion. So please make a note of your question and observation as you go along. I would now like to introduce the Clinical Director, Alan Tompkinson, who will introduce the presentation. Thank you, Alan.
Well, good evening, everybody. So my name's Alan Tompkinson. I'm the Clinical Board Director at Cardiff and Vale. And so first, I'd like to just say a big thank you to everybody that's taken the time to join this meeting this evening. And I'd also like to particularly thank South Glamorgan Community Health Council, who've been really so helpful in making this event happen. Can I have the next slide, Ala, please? So this is a brief run through of what we're going to talk about tonight. Explains you what vascular services are, how they're provided at the moment, why we've taken the time to talk to you tonight, what we do, the proposed new model of care, how you can possibly get involved, and an opportunity to speak to the panel that's here tonight. So next slide, Ala. So I'm Alan Tompkinson, as I've already said, and I've got Dr. Kevin Conway and Janina Conway, who's going to take the rest of the slide presentation and talk you through what the service changes are and what vascular surgery is all about. And I'll hand over to them. They may want to introduce themselves and give a bit more detail about their background also. Thank you.
Thank you, Alan. Thank you, Malcolm. My name is Kevin Conway. I'm a consultant vascular surgeon and the clinical lead for vascular surgery in Morganach and Cardiff and Vale University Health Board.
Hello, I'm Janina Conway. I'm one of the specialist nurses in the vascular unit at UHW. I'm involved with patient care from the outpatient clinic through theatres, ward cover, throughout the whole sort of journey that they'll have.
Next slide, please, Ella. Okay. I think I'll take it from here. So the aim of tonight is to discuss the changes proposed for vascular surgery in South East Wales. Next slide, please, Ella. Okay, so what are vascular services? So essentially, we vascular surgeons deal with diseases of blood vessels, which can cause narrowings, blockages, or dilatation of arteries. The aim of our surgery and our treatment is to restore blood flow to the limbs, organs, and prevent the catastrophic complications of sudden death, stroke, and the need for limb amputation. We also aim to improve the quality of life and function for our patients. Next slide, please, Ella. So, vascular services, blood vessels may be damaged through injury, but thankfully in the UK, that's a relatively uncommon thing to happen. A much more common cause of vascular disease is diabetes, smoking, and increasing age. Therefore, vascular surgeons and specialists have to work very closely with the trauma surgeons, the cardiologists, and the diabetic, stroke, and kidney specialists. Next slide, please, Ella. So, who needs vascular services? Essentially, those patients who have injuries compromising the blood supply to their organs or limbs. Vascular surgeons can reduce the risk of you having a stroke with an operation to clean out the arteries going to the brain. We can also do procedures to improve the blood supply to the arms, legs, guts, and kidneys. Next slide, please, Ella. Traditionally, starting back in the 1950s, most large hospitals providing surgery also did vascular surgery. But by the 1990s, it was becoming apparent that large units doing large amounts of vascular surgery were having much better outcomes than smaller units doing small numbers of operations, usually done by general surgeons. Therefore, our governing body, the Vascular Society, advised regions should pool resources. So in South East Wales, we agreed that there should be a single hospital in each health board providing vascular services and surgery. So for Cardiff, that was the University Hospital. Back before the Grange Hospital was built, it was the Royal Gwent. And in Morganach, it was the Royal Glamorgan. Next, please. Next slide, please, Ella. Why are we talking about this issue? Well, we have lots of challenges in vascular surgery. Probably the main one we have is recruitment and retention of surgeons, radiologists, and vascular nurses. We also have national standards, which we must adhere to, which state that we must have a population of at least 800,000, which we serve. And currently, none of the 3 health boards in South East Wales are that big. And as a result, our services are spread very thinly across multiple sites. Our outcomes are good, but they could be better. So rearranging services will hopefully improve the outcomes that we have and bring us into line with South West Wales and with North Wales. Next slide, please. All practicing vascular surgeons must submit their outcomes from operations to what is called the National Vascular Registry. This is a registry of all vascular surgeons in the United Kingdom and Ireland. And this gives us an opportunity to compare ourselves with previous years and with other units the same size. And we have to report in 5 key areas. Aortic aneurysms, which is a dilatation of the large blood vessel in the tummy. Carotid endarterectomy, which is the unblocking of the neck arteries going to the brain. Leg bypasses, which are surgical procedures to improve the blood supply to the feet. Angioplasty, which is a keyhole technique where we use a small balloon to stretch up narrowings within the arteries, and major limb amputations of the lower limbs. And if you want to see any of our outcomes, you can use the link shown to look at this. Next slide, please, Ella. As I previously said, our results are good, but they could be better. By rearranging services, we will come into line with the rest of Wales and the UK. We also make best use of our existing and future workforce. This will hopefully help us to improve recruitment. And on that note, we recently appointed a new surgeon who trained in the West Midlands, and we hope to appoint another surgeon after Easter. Next slide, please, Ella. I've personally been involved in this process going back to 2013. In 2014, we convened a large panel drawn from all of the health boards, and we looked at the options for vascular services in South East Wales. And we looked at the 6 areas shown. Next slide, please, Ella. And we did come to a collective agreement. We agreed the best option to deliver care for vascular patients was through a central hospital, which would be called the hub, but with the support of spoke hospitals in each of the 3 health boards. This would mean that all major vascular operations are done in one hospital, but the patients could then recover or rehabilitate in a hospital closer to home. This will make best use of our skills and staff, and it will, as has been shown previously from other areas, improve outcomes for our patients. Next slide, please, Ella. Have we given thought to where the hub should be? The process, the options appraisal from 2014 was a very rigorously scored meeting. And we scored all the options and unanimously came to the agreement that the hub would be the University Hospital of Wales. And since then, the Major Trauma Centre for Wales has opened in UHW, which I think reinforces that we made the correct decision. Next slide, please, Elva. We will plan to maintain spokes in the 3 health boards. In Iron Bevan, when we did the options appraisal, it was agreed to be the Royal Gwent Hospital. Since then, the Grange University Hospital has opened, and it will be a mixture of services between the Grange and the Royal Gwent. In Cwmtaf, the spoke will be the Royal Glamorgan Hospital, and in Cardiff and Vale, the spoke will be the University Hospital Clondock. And this just means that rehabilitation will continue to take place through local hospitals across the region, with patients being treated closer to home following their surgery. Next slide, please, Ella. So what does this mean for our patients? Well, for the patients, it shouldn't make a lot of difference to start with. You still attend, if you have a vascular emergency, your local A&E department. You'll be assessed by the doctors in that hospital. And if it's deemed that you need treatment by the vascular surgeons, you'll be transferred to the University Hospital for your procedure. And following the operation, if you need time to recuperate or rehabilitate, you'll be transferred back to the spoke hospital closer to home for that treatment. Next slide, please, Ella. We're very keen to get everybody involved. We'd like you to visit our website and take part in the survey. We'd be very keen to hear your feedback and be grateful if that could be received by the 16th of April. And you can also contact us by email, telephone, and social media. Next slide, please, Ella. We are keen, as I said, to hear your views, especially on the recommendations for the hub and spoke model, but also the proposal for the University Hospital to be the hub site, and for the suggested arrangements for the spoke hospitals. Any other information we should consider in future services, and the process is undertaken to reconfigure those services. And we'd also be keen to hear any alternative views on the proposals put forward. Thanks, Malcolm. Sorry, Ella, next slide, which I think is just any questions. Okay, sorry, I've got ahead of myself.
Okay, thank you, Kevin. I would like to thank Kevin, Janina and Alan for the presentation for the Health Board. It's now your turn to provide comments, questions and observations, all of which will be noted for reference as part of the engagement process. Ideally, I want to afford all present the opportunity to have their say and not to cut short any debate or discussion. To help this, I would like us all to follow the following. Firstly, could all speakers please give their name, and if you are representing an organisation, the name of that organisation and your position within that organisation. Secondly, it would be appreciated if only one person would speak at a time, again to assist everyone at the meeting and to help the note taker record the question and the answer. Thirdly, I want you to act kindly, and I'm sure I don't have to ask attendees to conduct themselves with dignity and refrain from engaging in any personal attacks or to act in an aggressive manner. Finally, I would like to invite questions and attempt to limit them to one per person in the first instance in order to allow as many people as possible to contribute. It is my intention to finish no later than 9 p.m. So could I have the first question, please? If you want to raise a question. Yes, Caroline?
Good evening, Caroline Harris. I'm complaints advocate for the CHC, but it's a personal question to ask about repatriation. Obviously, everybody's going to be in UHW initially, and even now, the problem about repatriation once somebody is recovering and needs to go back to their own area is a huge struggle. So I'm just wondering if that's going to be taken into consideration, because it's a number of health boards that are involved rather than just sort of one health board area. Thank you.
Malcolm, would you like me to take that one?
Yes, if you take that one, Kevin.
Thank you, Caroline, for the question. I'm not sure if you're aware that Cwmtaf Morgannwg moved their service as an emergency measure back in September of last year. It came about because we lost our interventional radiologists. Two of them left in quick succession. So we've actually been doing this for approximately 6 months, where Mike Rocker and myself treat the Cwmtaf patients in Cardiff, and we then repatriate back to Cwmtaf. We've got very robust spoke models in place already. We've got very good working relationships with our medical colleagues in Cwmtaf. And we tend, depending on where our patients live in the Rhondda or Cunnan valleys, refer to Spitty Cum Rhondda or Spitty Cum Cunnan. And I'm sure Janine will tell you that our discharges are actually very good, probably because we do have the 2 hospitals which are designed for rehab. But we discharge our patients very rapidly. I think AB plan to have something very similar to what we have, because they've got multiple sites. The issue is in Cardiff, which doesn't have a rehab hospital. but a lot of work is being done currently in the spoke site for UHL. So I think things are okay at the moment, and I think they will get better as the new site in UHL is built.
Thank you.
I'm not sure that really answered your question.
Oh, but it does. Thank you.
Thank you.
All right. Anybody else with a question? Yes, Steve.
Hi, Steve Nicholl. Thank you, Chair. Steve Nichols, South Glen Community Health Council. I was thinking about the recruitment issue. Obviously, it was good news about the extra surgeons coming on board, but I'm acutely aware about the interventionist radiologists. There seems to be a national shortage of that particular specialty. Is there a danger you may not have the critical mass of staff to be able to organise at this level? Having said that, I think the logic of the proposal is very sound. Thank you.
Malcolm, would you like me to take that one?
Yeah, take that one, Kevin, and then I'll bring Greta in afterwards. Okay.
Okay. In South East Wales, we're actually very lucky. We're the only region in Wales that has a 24/7 IR on call. Currently, we have 7 full-time consultants manning the rota in South East Wales. Ideally, for our population, we should have 8. We have 3 senior IR trainees in training in Wales who have indicated, promised that they want to work in South East Wales. We do potentially have some retirements coming up, but we feel quite comfortable with our IR service in South East Wales. I think, yeah, there are issues in the rest of Wales which is exacerbated by the national shortage of IR consultants.
Yeah, thank you for that. I did notice, I think, in the slides too, that about 1,300 procedures in an average year, I think I saw. I'm just wondering, obviously, there's with the COVID situation there, that's probably decreased substantially, although some of it may have been outsourced to private hospitals, I'm not sure. I'm just wondering about, putting together this critical mass within South East Wales. You'll have to address the backlog as well.
Is it okay, Malcolm, if I take that again? Okay, thanks, Steve. We don't outsource any vascular IR.
Okay.
We have in the past outsourced varicose veins, but arterial and IR work is never outsourced. Admittedly, our procedures have gone down during COVID because we didn't do any lifestyle limiting conditions. We've only done limb-threatening conditions or life-threatening conditions. We are seeing a definite uptick in late pathology, but vascular surgery is definitely an urgent and emergent service. We don't have waiting lists like the general surgeons or the orthopedic surgeons. So if you need treatment, you will have treatment. You may be in hospital waiting for that treatment, but if we delay, you lose your leg. So we're desperate for that not to happen.
Yeah, no, thanks for that. I mean, obviously there's some other issues such as perhaps longer travel times for certain areas as a result of putting the centre in Cardiff. But as I said, I think the logic of it is very sound. Thank you.
Thanks, Steve.
I think Greta Sains, you wanted to come in?
Yes, you may have already partially answered the question. Should someone go to the hub, then they're sent back to rehab, God forbid they have a problem, where will they be treated? Will they be sent back to the hub, because that could maybe cause problems, or would you be able to treat them within the spike area?
Okay, Kevin, do you want to?
Janina might be better placed to answer that one, or?
Okay, Janina. You're on mute, Janina. You get the prize tonight for the first on mute.
All right. I think in regards to the initial sort of post-operative period, obviously we try and keep patients in the hub, depending on the type of surgery they had, maybe 7 to 10 days. If there's going to be any social issues or any extra therapy, so physiotherapy, OT to plan discharge, obviously we would then plan and, as Kevin said earlier, repatriate to the spokes. If there was a problem in the spoke, we have quite a robust service where we'd be easily contactable. So we all sort of, we have Consultant Connect, where the consultant who's on call that week is accessible. We'll be having hot clinics, so patients could come back if it was just a wound check or something like that, rather than an acute admission that they require. But if they did need inpatient care, then I think they would then come back to the hub, you know, should they need any redo surgery, or there was any concern regarding any grafts they had or anything like that. So there would be cover at the spoke for certain wound checks, etc. But anything of concern, they would be able to be seen back at the hub or a local spoke clinic if that was felt appropriate.
Great, thank you. Amy, I think you want to come in. I'm not sure if you want to come in afterwards, Ivan. We weren't sure whether it's the light on your glasses or you're trying to get attention. Okay, Amy. Amy.
Diolch Malcolm. Swyddog Cymorth Eifiolaeth ydw i am Cyngor Iechyd Cyfuned De Morgannwg.
CHC Glamorgan. My question is, if the stroke service is located in Llandor Hospital, how will individuals that live elsewhere will be able to travel to Llandoff if there are problems with public transport or other problems that they can have to have access to the services?
Anyone want to come in on that one? It's about accessibility and travelling to Llandoch.
Malcolm, do you want me to take this?
Yes.
Thanks, Amy, for that. This is a very topical issue for us at the moment. We are very keen for patients not to be making unnecessary journeys to hospital. I've traditionally covered Prince Charles and Royal Glamorgan. Some of my patients would have to take 3 buses to come to see me in clinic. We've made a lot of use of virtual clinics recently, especially during COVID. We use Attend Anywhere, we do telephone clinics. I was always under the impression that a lot of patients wanted to come and see me. I'm really surprised how much they would rather talk to me on the telephone. And I'm also really surprised how tech savvy a lot of my patients are. They're elderly, but they're very good with technology. Again, I was surprised how much you actually can do in virtual clinics. I was always taught that you need to see and examine the patients, but actually, you know, a good chat with the patients, you get a lot of information. Sometimes, you know, they have to come and see you, and we can make use of hospital transport, but more and more we are using virtual clinics. And as I said, the feedback from the patient has been really good, and we hope to expand that further. Sorry, Amy, did that answer your question?
Yeah, rai o'r question.
Yes, parts of the question. But can you ask anything else?
Sorry, Amy, I only caught the tail end of the translation.
Yeah, that did answer part of my question. I'll switch to English if that's easier.
It's just, I keep missing out with the translations.
That's okay. The point I was trying to make is if obviously they were an inpatient in the hospital, whether that being in the heat having their surgery or whether it being in the spoke service in Llandoch, if their family and friends live in either area, both different parts of Cardiff, then obviously, and they can't travel to see their family, could any sort of provision be put in place, or would there possibly be an option for them to be seen in a different hospital that would suit them better in terms of travelling, or if there was problems with any sort of transport or having links to their family and friends, really?
Thanks, Amy. Yeah, apologies. we always try to see patients as close to home as possible. And as I said, I've traditionally covered Cwmtaf. We make a lot of efforts so patients are always seen closer to home. Yeah, it is something we endeavour to do. It's something that in the past we haven't got right all the time, and I think it's always a learning experience, and it's good to get patient feedback. If we're not doing it as well as we should do, we want to hear that to see how we can improve the service.
Thank you.
Abby, I think you wanted to come in as well.
Yeah, thank you, Malcolm, and apologies for joining a little late this evening. I had trouble getting in. So just to add to Kevin's comments, I guess that's one of the issues we have across a range of services, Amy, where we will have some services delivered in Llandoch and some delivered in UHW, I guess what we're trying to make sure, in addition to what Kevin's saying, is that people should only be in hospital or have a hospital appointment when that's absolutely necessary to them. And I guess in this model, the separation with the rehabilitation means that that we can really create the right kind of environment at UHL for the rehabilitation phase for individuals. And as part of wider work that we're doing, we're trying to make sure that we're working with the councils to make sure that there is good public transport links to both of our hospitals, and to try and make it easy, think through things like the park and rides, so that that family and friends can get to visit it easily, and that we can address that as part of that ongoing conversation about improving transport links. So it is something we're very mindful of, and of course people come from from all over the Cardiff and the Vale for both of these services and both of these sites. So it's trying to make sure we build that into our planning as much as we possibly can. So important point to raise. Thank you.
Thank you. Okay. Ivan, did you actually want to raise? You're still on mute, Ivan. Should be okay now.
Okay. Question yn Gymraeg, os gwelwch chi dda.
Question in Welsh, please. My name is Avian Pritchard, a member of the council. Is there a day-to-day connection between this department and the hearts department or the cardiological department? Is there a close connection on a day-to-day basis? Is this change going to affect this to an extent at all?
Okay, Kevin, I have one for you probably.
Thanks, Avian. Yes, we work very closely with the cardiologists. Our ward is actually B2 vascular and the cardiologist is B1. They're literally a flight of stairs below us. There isn't many days that go by that we aren't called by the cardiologist or vice versa. We've got very good working relationships with them, and I'm sure that doing this will just improve those relationships and services.
Thank you.
Can I bring Stephen Allen in now?
Thank you, Chair. Just wanted to ask a question, I don't think, sort of for the team. So just for the people who may not understand this. So currently the service in Cardiff and Vale is we got it based at UHW, I understand. Can I just ask, what's the, from a Cardiff and Vale resident's point of view, is there any major change to the service that we currently access and have, or will this be seen as an improved service because we'll have a rehabilitation element at Llandoch? So could you just explain that to me, please? And that may be helpful for people who are listening or may watch this for you sort of later on.
Malcolm, would you like me to take that one?
Yes, fine, Kevin, if you take that one up.
Thanks, Steve. Yes, you've made a really good point. Everybody's always worried that if you move services in from surrounding areas, that it dilutes the service that we currently deliver. I think the opposite is actually the case here. And Cardiff and Vale has had 3 vascular surgeons. When we complete the centralisation, we project we'll have 11 surgeons. This gives us a lot of opportunities to cover services that we don't cover currently, such as MDTs and other specialities. It also allows people to develop specialty interests or subspecialty interests and skills that, because you're so busy delivering a general service to your population, we haven't had an opportunity to do so far. A lot of the new consultant and one of our prospective candidates for the new job have got really good skills that we don't have locally. And we hope to develop new services such as a deep venous service for the management of DVTs and for chronic venous conditions. And it's a very exciting time for us because the one thing about surgeons and vascular surgeons in particular is that they love their new treatments, and this will hopefully give us an opportunity to develop the service significantly. It seems mundane to us, but rehabilitation, prehabilitation, these are so important to our patients, especially post-COVID. We're finding a lot of our patients are very deconditioned, and it's something that probably has been neglected in the past. And if what we all want from our surgery and our procedures is a good outcome for the patients. So I personally think this is a really good time for us, for any sort of vascular surgeon, but hopefully also for the patients getting a better service.
Can I come back on that one as well, Kevin, if that's okay with you, Chair? Is obviously people in Cardiff and Vale would look at this being obviously it should be a South East Wales service. So therefore, currently we would obviously be referred in and would be seen sort of within that tranche of patients currently with the services being out elsewhere. But obviously if it's centralised, would there be a risk that patients in Cardiff and Vale who are referred in may have to take their turn in the queue for people to access this service? And what assurance can you give to people in Cardiff and Vale that actually they won't be disadvantaged by having other areas coming into the hub? We understand the rationale behind that, but sort of from a purely Cardiff and Vale perspective that we're obviously there to represent, what assurance can you give that actually Cardiff and Vale residents won't be less sort of disenfranchised with having other people coming into that queue?
Chair, can I come back to that one, please?
Yes, by all means, Kevin.
Thanks, Malcolm. Thanks, Steve. You've made some really good points. But when there was only 3 surgeons in Cardiff, they weren't able to deliver some of the newer arrangements in vascular surgery. The big one is what we call consultant of the week, where there's a dedicated surgeon who's relieved of all routine clinical commitments. So they're available to deal with any urgent patients, emergent patients, any problems in theatre or in the cath labs. So we've developed the consultant of the week. We want to develop that further into what's called the surgeon of the week. So there'll be a second tier of on-call where a consultant will be free, so that if there's a problem in any surrounding hospitals, that they're free. Say if the orthopedic surgeons have a problem with a blood vessel in Clandock, somebody will be immediately freed up to go to Clandock. It's also allowed us to develop hot clinics. So as Janina mentioned, we are now contactable through what's called Consultant Connect, which is an app that the GPs and other clinicians within the hospital, rather than going through switchboard, they literally use the app, press 2 buttons, literally turn the app on, click on vascular surgery, press ring, and we have 3 tiers of on-calls for people to speak to them. We have hot clinic slots every day, which we didn't previously have, so that those patients are either seen the same day or the next day. And then moving forward, it's allowed us to justify what's called the hybrid theatre, which we wouldn't have been able to justify before, which is the state-of-the-art theatre complex where we have imaging C-arm technology in the operating theatre, so we can do what are called hybrid or interventional procedures as well as surgical procedures. But we can also quality assure our operations, so we can do an angiogram at the end to show that the operations actually worked and we've made a difference to the patient. So I think without the process of vascular redesign or centralization, none of that would have come about. So I think it's a win-win for all the patients, but also for the staff as well.
Sorry, Chair, can I come back? I don't think you answered the question there, Kevin. Sorry, and that was actually about the Cardiff Vale residents, obviously, who currently access the service. Are you able to sort of give some? I'm not saying a cast iron guarantee. I would never do that, but sort of some assurance that they're not going to be sort of waiting now in a relatively longer queue, because they've got people from Cwmtaf, South Powys, AB, and sort of that area coming into the area now to have their services, have their operation within UHW, whereupon before they didn't have to wait in that long queue. So can you give that, are you able to give some assurance on that, please?
Okay, so previously the ward capacity in Cardiff was 19 beds, which was shared with general surgery. That's going to be increased to 38 beds. So we get an entire ward to ourselves. Previously, they had 3 days of operating, and we've been given 8 all days of operating. We've also increased our capacity in radiology with new rooms, and now we're going to have the hybrid theatres. As I mentioned, we've increased the capacity in outpatients to see patients as urgents. We're going to increase the footprint of the surgical assessment unit. That's going to be doubled in size. So yeah, John, nobody's going to be disadvantaged from this. I personally can only see advantages. I'm not sure if that's answered the question this time.
Sorry, Kevin. I think Abby wanted to come in, Chair.
Yeah, I just wanted to add to what Kevin said. Really, I agree with Kevin. I think that that the all of the component parts that are coming together with this change will actually give greater robustness to the service we're able to offer the Cardiff and Vale patients as well. In terms of the critical mass, that will benefit our patients just as much as it will benefit those others that will come in and be seen under this. So my sense is that we'll end up with a more resilient and more robust service, which is only going to be better for the Cardiff and Vale patients. So Stephen, I think you can take assurance from that. I mean, obviously there will be periods where you get a blip in demand, but our ability to manage the peaks and troughs in activity will be greater, I think, because of the component parts of the service coming together in this way.
Thank you.
I think Alan wanted to add something as well. He's got a hand up as well, Malcolm.
Okay, Alan. You're on mute, Alan.
Oh, sorry.
That's okay.
Yeah, so I just wanted to just add to what Abby and Kevin had just said. So one other thing that perhaps you might not understand from the conversation so far, though Kevin did touch on it, the vascular surgeons being present in the hospital are a very useful resource for lots of other specialties. So when surgeons get into trouble, perhaps taking a kidney out, or perhaps doing something with bowel, or maybe with an orthopedic surgeon, they sometimes do find themselves in trouble and they can't stop bleeding and the patient's at risk. And having these guys nearby can be absolutely key to rescuing the situation. And it's one of the reasons why major trauma could only be in Cardiff, because of the vascular surgeons supporting that. If somebody gets into major trouble from a smash or a major accident, the vascular surgeon is one of the key personnel having nearby and having free of any other responsibilities to come and rescue the situation. So they're very important people to have around, and we are, I think I can give as much assurance as I can give that the residents of Cardiff are going to be in a safer place as a consequence of this.
Thank you, Alan.
Chair, can I just come back on that, if that's okay? Because I think that's what I was trying to aim at, really, was trying to get that on behalf of the public, really, to actually get that assurance. Because I know that we've received it as a CHC, but obviously for people who may watch this or maybe in the meeting now, I don't think that comes through on the presentation as from a Cardiff and Vale residents' point of view. That's why I was asking the question.
Okay, thank you. I think Alan's been very clear as well as to the benefits.
Yeah.
So, thank you for that, Alan. Are there any other questions? Everybody's being very quiet tonight.
There's nobody got their hand up, Chair.
Oh, sorry, Steve.
Yeah, thank you, Chair. It's the old chestnut, I'm afraid, of the hospital-acquired infection rate. I know that the cardiac area had problems last year at one stage and was reduced to, I think, emergency only. And with the vascular services nearby, I think perhaps the public would need some reassurance as well, but you know, the situation is under better control. I'm pretty sure it is, but just for the record, really, that the problems that were encountered last year perhaps have been ameliorated now. Thank you.
Okay, thank you. Is there a response to Steve that, or
I think Alan's got his hand up, Chair.
okay, Alan?
Sorry, have I got my yeah. Yeah, if I could just come back on that. So yes, you're absolutely correct. We have had problems in the past and have done many things to try and mitigate those problems. Interestingly, we've learned a huge amount through the last 12 months with COVID. And I'll just frame a couple of things for you that you might not be aware of. So in response to COVID, we had to divide up the hospital somewhat differently. And I'm not sure how much detail you're aware of that, but we've created separate zones for time critical surgery that is separated from the emergency flow, because anybody coming in for elective surgery, that's routine surgery, not emergency surgery, needs a guarantee that if they come in there, they're not going to get into the difficulties you described about hospital-acquired infections. And so I'll give you a headline figure, which through those green zones, and there was one in Cardiff in the Heath, one in Cardiff in UHL, and the third when we utilised Spire Hospital, which we took over. Most of it's been handed back now. But the headline figure for you is that in all of those green zones, we've put 5,000 patients through there. Not a single case of COVID to one of those patients. Not a single case of Clostridium difficile, MRSA or MSSA. They're the serious infections that you get following surgery. We have had some infections in the emergency stream, but that was to be expected. And we've had much more difficulty in controlling COVID in the emergency stream. Now, a lot of vascular surgery does take place in that emergency stream. Some of the more elective work will take place inside our green zone. And we are very keen as surgeons and as a health board to maintain those protected zones. We're calling them protective elective zones because of the benefits that we've now seen, that patients actually get treated, they get guaranteed bed, they go home, they go back, go to theatre, to ITU, to the HDU area, and then back to a protected bed. So we've learned a huge amount about how to protect patients from post-operative infections and ways of doing it. And we're hoping to, keep what we've learned. So we're very pleased about how that's gone. So things have changed significantly, Steve.
Yeah, thanks for that. I was aware that zoning was proven to be efficacious. It was just that, if you read some of even the quality newspapers, for example, you'll read something like 7 out of 10 cases, I think, in England at one stage in December were hospital acquired with COVID. And it's that sort of reassurance I think that people would need now.
Mm-hmm.
Thank you.
Thank you, Steve. Okay, so that's the last call for any final questions. Okay, well, I think that naturally, brings us to the end of this online engagement meeting. I wish to thank the speakers for their input and also for their honest answers as well. I think they've answered honestly and as open as they possibly can. And also the clinicians who have taken part. I especially thank you for attending and feeding in your comments, questions and observations into the meeting. We will ensure that your views, comments and observations you have expressed will be taken into consideration in the discussions that the CHC will have following the end of this engagement exercise in order for the CHC to formally respond to the Health Board. Could I also remind you that you have the opportunity of having your voice heard is to complete the questionnaire and return indicated on the form. You also have the opportunity to contact the CHC if you want phone call right through to text, email or letter if you have some other points you wish to raise, which you may think of afterwards. Finally, thanks once again for attending, and can I just ask Alan to bring the meeting to a close?
Yes. So yes, again, so if I just thank everybody for spending the time with us this evening to ask us the questions that you have, and hopefully that we've reassured you of by answering those questions as fully as possible. There will be another meeting on this coming Thursday. If any of you wish to attend again, or if you know of anybody else who you'd like to suggest that would like to attend, and you can do that by registering via the Health Board website. And again, can I thank the CHC for all the effort that they put into putting this together for everybody tonight.
Okay, thank you. Thank you, everyone. I wish you good night and a safe, well, I usually say safe journey, but there's no journey tonight.
Downstairs.
It's one of the advantages, isn't it? Thank you, Malcolm. Yeah,
Thank you.
I'll just echo Alan's thanks. Great.
Thank you. Bye-bye.
Good night.
Bye-bye.
Bye.